20. Emergencies. Aura. Subjective sensation or motor phenomenon that precedes and marks the onset of a paroxysmal attack, such as an epileptic attack. Automatic external defibrillators, AEDs. Device used for application of external electrical shock to restore normal cardiac rhythm and rate. Cardiac arrest. Sudden stoppage of cardiac output, ineffective circulation. Cardiopulmonary resuscitation, CPR. Artificial substitution of heart and lung action is indicated for cardiac arrest or apparent sudden death resulting from electric shock, drowning, respiratory arrest, and other causes. Cerebrovascular accident, stroke or brain attack. Condition with sudden onset caused by acute vascular lesions of the brain, often followed by permanent neurologic damage. Claustrophobia. An extreme fear of enclosed or tight spaces. Emergency. Unexpected or sudden occasion, an urgent or pressing need. Epistaxis. Nosebleed, hemorrhage from the nose. Erythema. Redness of the skin, typically caused by irritation or injury. FAST scan. Acronym for Focused Assessment with Sonography for Trauma, a bedside sonography exam used to assess trauma patients for internal bleeding. Hemorrhage. Escape of blood from the vessels, bleeding. Hyperglycemia. Abnormally increased concentration of glucose in the blood. Hypoglycemia. Abnormally diminished concentration of glucose in the blood. Lethargy. Abnormal drowsiness or stupor, a condition of indifference. Nausea. Unpleasant sensation, vaguely referred to the epigastrium and abdomen and often culminating in vomiting. Pallor. Paleness, absence of skin coloration. Shock. Condition of profound hemodynamic and metabolic disturbance characterized by failure of the circulatory system to maintain adequate perfusion of vital organs. Syncope. Temporary suspension of consciousness as a result of generalized cerebral ischemia, faint or swoon. Urticaria. Vascular reaction, usually transient, involving the upper dermis, representing localized edema caused by dilatation and increased permeability of the capillaries and marked by the development of wheals, also called hives. Ventricular fibrillation. Disorganized cardiac rhythm. Vertigo. Illusion of movement, sensation as if the external world were revolving around the patient or as if the patient were revolving in space. Vomiting. Forcible expulsion of the contents of the stomach through the mouth. Wounds. Bodily injuries caused by physical means with disruption of the normal continuity of structures. Wound dehiscence. Separation of the layers of a surgical wound, may be partial, superficial only, or complete, with disruption of all layers. The technologist should keep in mind the following priorities when working with patients in emergency situations. 1. Ensure an open airway. 2. Control bleeding. 3. Take measures to prevent or treat shock. 4. Attend to wounds or fractures. 5. Provide emotional support. 6. Continually re-evaluate and follow up appropriately. The ready availability of emergency equipment and drugs in the form of a crash cart reduces the time required to respond to a medical crisis. Equipment may include backboard, stethoscope, blood pressure cuff, ambu bag, laryngoscope, flashlight, batteries, extension cord, oxygen flow meter, tourniquet, endotracheal tubes, nasopharyngeal tubes, suction catheters, Levine tubing, Gelco cannulas, tracheal tubes, cut-down tray, suction bottle, hemostat, scissors, sterile gloves of various sizes, syringes of various sizes, needles of various sizes, stopcocks and connectors, tongue blades, sterile gauze, adhesive and paper tape, alcohol swabs, surgical lubricant, blood collection tubes, povidone iodine swab stick, defibrillator and monitor or an automatic defibrillator. Drugs may include adenosine, adenocard, for arrhythmias, amiodarone, cordarone, for arrhythmias, atropine for bradycardia, dexamethasone, decadron, for allergic reaction, dextrose for insulin-induced hypoglycemia, diphenhydramine, Benadryl, for allergic reaction, dobutamine, Debutrex, for shock, dopamine for shock, epinephrine for cardiac arrest, anaphylaxis, furosemide, Lasix, for edema, naloxone, Narcan, for opioid overdose, Nitroglycerin spray for angina. Norepinephrine for shock. Phenytoin, Dilantin, for seizures. Procainamide, Pronestil, for arrhythmias. Sodium bicarbonate for metabolic acidosis. Verapamil for arrhythmias. AEDs come in the following two primary types. 1. Fully automatic defibrillators, which analyze the patient's cardiac rhythm, determine whether defibrillation is necessary, and, if necessary, deliver a shock. 2. Semi-automatic defibrillators, which analyze the patient's cardiac rhythm, determine whether defibrillation is necessary, and, if necessary, advise the operator to deliver a shock by pushing a button. Of the several ways to categorize head injuries, the simplest form of classification is by level of consciousness. The patient with the least severe injury is classified as alert and conscious. In most instances, this patient can respond fully to questions and other stimuli. A more seriously injured patient is drowsy but can be roused to response with loud speaking or gentle physical contact. Even more serious injury produces a patient who is unconscious and reacts only to painful stimuli. These patients typically do not respond to verbal stimuli but react to stimuli such as pinches and pinpricks. The most serious condition is that of a patient who is comatose and unresponsive to virtually all stimuli. Findings in an alert or drowsy patient that can signify a deteriorating head injury include irritability, lethargy, slowing pulse rate, and slowing respiratory rate. If the radiologic and imaging science professional recognizes a deteriorating head injury, the first priority is maintaining an open airway while moving the patient as little as possible. The procedure should be stopped and medical assistance obtained quickly. The radiologic and imaging science professional should obtain the patient's vital signs while waiting for help to arrive. The following types of shock can occur. Hypovolemic shock, caused by loss of blood or tissue fluid. Cardiogenic shock, caused by a variety of cardiac disorders, including myocardial infarction. Neurogenic shock, caused by spinal anesthesia or damage to the upper spinal cord. Vasogenic shock, caused by sepsis, deep anesthesia, or anaphylaxis. The radiologic and imaging science professional is most likely to encounter hypovolemic shock or anaphylactic shock, a special type of vasogenic shock, as a result of a reaction to contrast media administered in the course of a medical imaging procedure. It is important to keep patients covered to maintain normal body temperature. To avoid overheating the patient is equally important. Pain, stress, and anxiety also contribute to the development of shock. Signs and symptoms that a patient might be going into shock include restlessness, apprehension or general anxiety, tachycardia, decreasing blood pressure, cold and clammy skin, and pallor. Because the most severe reaction can result in death from cardiac arrest, contrast media should not be administered without first taking an adequate history. In general, the longer it takes for a contrast media reaction to develop, the less severe it is. Accordingly, the most severe reactions typically arise very quickly. Mild reactions are similar to other allergic reactions. Patients develop localized itching and urticaria, hives, and may experience nausea and vomiting. Generalized itching and hives are indicative of a systemic reaction, which is generally more serious than most mild reactions. The most serious reactions might include laryngeal edema, shock, and cardiac arrest. Many patients who undergo radiologic and imaging science procedures are required to have had gastrointestinal, GI, preparation, which might include a special diet or fasting. Such alterations in dietary patterns can be particularly troublesome for patients with diabetes. If no food is eaten, administered insulin depletes the body's energy store, leading fairly quickly to insulin shock, sometimes called an insulin reaction. Patients who are experiencing this condition are intensely hungry, weak, and shaky and may sweat excessively. They also may become confused and irritable, sometimes to the point of aggression and mild hostility. The patient needs a quick form of carbohydrate. The patient should be encouraged to sit quietly until the food has had a chance to take effect, usually 10 to 15 minutes. Hyperglycemia is a condition of excessive sugar in the blood and is the characteristic typically associated with diabetes. This condition develops gradually, generally over a period of hours or days, so it is not likely to be noticed by a radiologic and imaging science professional. These patients exhibit excessive thirst and urination, dry mucosa, rapid and deep breathing, and drowsiness, and confusion. The condition leads to diabetic coma if left untreated. The patient needs insulin. Respiratory distress is another medical crisis that occasionally occurs in the radiology department. Asthma attacks are often triggered in asthmatic patients when they are exposed to stressful situations, such as might be experienced in a radiology department. A patient in respiratory distress generally exhibits wheezing, a result of dilatation of bronchi on inspiration and collapse on exhalation. A calm, confident manner is important when faced with a patient having an asthma attack. In cases of choking, either partial or complete obstruction, the patient should be encouraged to cough. If coughing is unsuccessful in dislodging the obstruction, the Heimlich maneuver should be used. To apply, the rescuer stands behind the victim and wraps both arms around them, clutching one fist with the other hand. The thumb side of the fist is placed in the midline of the victim's abdomen, above the navel and well below the sternum. With the rescuer's elbows held out from the victim, pressure is exerted inward and upward. Although each thrust should be administered separately, the procedure may be repeated quickly 6 to 10 times or until the obstructing object is expelled. An unconscious patient should be placed in the supine position. Once the patient is safely on the ground, CPR compressions should start immediately. Research has shown that chest compressions are more effective than abdominal thrusts in increasing intrathoracic pressure. The mouth should be checked for presence of the foreign body before each set of ventilations during CPR. These maneuvers should not be used with women in advanced stages of pregnancy or with infants or small children. Because abdominal thrusts can be dangerous for women in late stages of pregnancy, chest thrusts are used instead. In infants younger than 1 year old, a combination of back blows and chest thrusts is recommended. The infant is held by the rescuer along their arm with the head lower than the trunk and supported by holding the victim's jaw. With the arm holding the infant resting on the rescuer's thigh, the rescuer uses the heel of the hand to deliver 4 back blows between the infant's scapulae. While the rescuer continues to support the head and neck, the infant is turned over, and 4 chest thrusts are given with 2 or 3 fingers. Patients who are experiencing cardiac arrest generally report crushing chest pain, often described as feeling as though an elephant is standing on the victim's chest. Pain may also radiate down the left arm. Because cerebral function is generally impaired if the brain is deprived of oxygen for more than 4 to 6 minutes, CPR must be initiated immediately on verifying that cardiopulmonary distress exists. Healthcare professionals should spend no more than 10 seconds checking for a pulse. If no pulse is located in that time frame, then chest compressions should begin promptly. CPR provides external support for circulation and respiration and consists of 3 primary aspects historically known as the ABCs: airway, breathing, and chest compressions. Guidelines have replaced the ABC order with CAB, emphasizing the need, particularly for the non-healthcare provider, to start chest compressions first. The initial process should begin with 30 compressions at a rate of 100 to 120 compressions minute in a depth of 2 inches, followed by the establishment of an airway and rescue breathing. Perform rescue breathing by putting the palm of the hand on the victim's forehead and using the thumb and fingers to pinch the victim's nostrils shut. Place a face mask tightly over the nose and mouth and take a deep breath. Initially, blow 2 deep breaths, each of 1 second duration, into the mask, while watching to determine whether the chest is rising and falling. Then take another breath between the ventilations. The breaths should not be rapid or forceful. If the mouth is damaged or clogged, sealing the victim's mouth closed and sealing the mask around the nose of the victim is possible. Establish circulatory inadequacy by palpating the carotid artery. If after 5 to 10 seconds the pulse is absent, then proceed with continued closed chest compressions. Reassess after 5 complete cycles of compress zyans and ventilations, 30:2 ratio, by taking no more than 7 seconds to re-evaluate the patient. If breathing and pulse are still absent, then continue CPR, checking every few minutes for the return of pulse and breathing. The protocol for CPR with 2 rescuers is similar, but each rescuer independently performs compressions or ventilations with periodic switches of position. When rescuers become fatigued, an organized switch of positions should take place. When a rescuer is breathing for a pediatric victim, the volume of air should be just enough to cause the rise and fall of the chest. In performance of chest compressions on infants, the index finger should be placed on the sternum just under the point where it intersects with the intermammary line. Using the 3rd and 4th fingers, compress the sternum to a depth of 1/2 to 1 inch at a rate of 100 per minute. The American Heart Association guidelines recommend rescue breathing at a rate of 20 to 30 breaths per minute, or a 15:2 ratio of compressions to breaths in pediatric patients. For a child up to 8 years of age, the hand placement is the same as for an adult. The chest, however, is typically compressed with only one hand to a depth of only 1 to 1/2 inches. On a pregnant patient, an attempt should be made to manually relieve pressure from the patient's uterus off of the IVC in a two-person rescue. One person should push or pull the abdominal area off to the left side to allow adequate blood flow back to the heart. CPR is clearly not indicated in instances in which the patient's family, or the patient's physician has specifically requested that resuscitation not be done. Once begun, basic life support should, and for legal reasons, must, be continued until the victim resumes spontaneous respiration and circulation, a physician or other responsible healthcare professional calls a halt, or the rescuer is too exhausted to continue. Strokes are more likely to occur in older patients, over 75 years of age, but can occur in any adult. Warning signs include paralysis on one or both sides, slurred speech or complete loss of speech, extreme dizziness, loss of vision, particularly if only in one eye, and complete loss of consciousness. Because the potential for paralysis or loss of consciousness is present, the patient should not stand or be moved before further medical assessment can be made. Nausea tends to be both a psychologic and a physiologic reaction. Patients who follow instructions to breathe slowly and deeply through their mouths often become calmer, and nausea and vomiting are avoided. If the technique does not work and vomiting does occur, the patient should be in a position in which aspiration of vomitus into the lungs is not likely. Recumbent patients should be helped into a lateral decubitus position if possible. All patients should be provided with an emesis basin and moist cloths. Epistaxis, or nosebleed, is another common occurrence. Again, this event is seldom life-threatening. Patients should lean forward and pinch the affected nostril against the midline nasal cartilage with digital pressure, with the fingers. Patients should not be put in a recumbent position or instructed to tilt the head backward because this action allows the blood to flow down the throat, resulting in the patient swallowing it. If gentle pressure fails to stop the blood flow, a moist compress may also be applied, which will stop most nosebleeds. Vertigo is often a precursor to syncope. A patient who experiences vertigo should be assisted to a seated or recumbent position, which prevents injury from falling as a result of problems with equilibrium. Patients who arise from an imaging table often experience vertigo as a result of orthostatic hypotension. Syncope is a self-correcting, temporary state of shock and the result of lack of blood flow to the brain. Treatment is aimed at increasing blood flow to the head. The patient should be assisted to a recumbent position with the feet elevated. Any tight clothing should be loosened. A moist cloth may be applied to the forehead. A epileptic patient who undergoes a mild seizure, called focal aware or focal impaired awareness seizures, may experience a brief loss of consciousness or may stare into space for a brief time. A diagnostic test or procedure should be postponed until another time. Severe seizures, called tonic-clonic seizures, are characterized by loss of consciousness, stiffened extremities and involuntary contraction of muscles on either one or both sides of the body. The patient may drool and lose control of their bowels and bladder because of loss of muscle control. Tonic-clonic seizures, on average, last from 1 to 3 minutes. In case of severe seizures, the healthcare worker should follow 3 basic steps to maintain patient safety. First, stay with the patient through the duration of the seizure. Second, keep the patient safe by laying them down and supporting their head with a pillow to prevent the patient from hitting their head against the floor. Lastly, turn the patient on their side to prevent choking or blocking of their airway. Patients who are about to have a seizure will sometimes experience an aura. Make note of where the seizure began, whether it was one-sided or two-sided, which parts of the body were involved, its length and the person's symptoms following the seizure, such as confusion or irritability. In case of a fall, the technologist should attempt to minimize the physical impact of the fall to the extent possible by supporting the patient to the floor. If dressings covering wounds are clean at the outset of a procedure but become saturated, attention is needed. The saturated dressing should not be removed. Pressure should be applied directly over the saturated dressing, preferably with an additional sterile bandage pressed against it. Because clotting can take up to 10 minutes, the pressure may need to be maintained for some time. When a bleeding wound is on an extremity, the affected extremity may be placed above the level of the heart unless other problems that would contraindicate such a procedure exist. Sonographers working in an emergency department, ED, setting or in a trauma facility may find it necessary to complete a focused assessment with sonography for trauma, or FAST scan, on patients who report to the ED with any penetrating abdominal trauma or indication for internal bleeding. The FAST protocol is designed to quickly determine if a patient has internal bleeding in the most common dependent areas of the body. While it is faster than transporting a severely injured patient for a CT scan, it is less sensitive and less specific. Acute skin reactions such as radiation burns as a result of radiation therapy, or radiotherapy, are not an uncommon occurrence in the radiology department. Technologists should monitor patients for changes in skin color as reactions typically begin with erythema, or reddening of the skin. As treatments continue, radiation therapists may notice dry desquamation, or flaking and peeling of skin, loss of hair or pigmentation changes. Dehiscence refers to a situation in which a patient's sutures separate, allowing abdominal contents to spill out of the peritoneal cavity. No attempt should be made to replace tissues inside the wound, but a sterile dressing should be used to cover the area. Claustrophobic MRI patients may show symptoms such as fast, heavy breathing, the inability to remain still, nausea or lightheadedness and a racing heartbeat. Prior to beginning the scan, educating your patient on what to expect during their MRI scan has been proven to greatly reduce anxiety over the procedure. Because face-to-face communication between the MRI technologist and patient are not possible during the scan, utilizing the intercom to talk to the patient during the exam may alleviate additional anxiety. Providing patients with headphones with music to help eliminate the noise of the MRI scanner, giving the patient a squeeze ball that allows them to alert the technologist if they become anxious, and letting the patient know that the machine can be stopped at any point if the exam becomes uncomfortable are all ways to minimize anxiety. Open or short-bore MRI machines and mild sedation are possible options to consider in claustrophobic patients who require MRI imaging.